تنفذ قواعد ذهبية تأسس لطبيب المستقبل. وخليني اليوم صار ستيمولس من سؤال زميلكم أنطي هذه القاعدة العامة مو فقط تخص السي ان اس. طلاب لما تنسأل عن الساين والسيمتوم والكلينيكال برزنتيشن اوف certain disease لا تدرخها كما هي وتحفظ لستة وبعد فترة تنساها. as simple as this. شنو الديسيز؟ احنا عندنا تشو، هذا التشو ممكن يكون اورجان والاورجانز متجمعه الى سيستم، مو مهم. المهم احنا عندنا في التشو، هذا التشو يؤدينا الى فانكشن معين. هذا التشو خلينا نسميه ستراكشر بين قوسين اناتومي. there's anatomical structure. هذا الستراكشر يؤدينا الى فانكشن. ركزوا وياي طلاب، يؤدينا الى فانكشن. الفانكشن شنو سميناها؟ وين ندرس الفانكشن؟ بالفسيولوجي. فإن اديزيز الباثولوجي بالبدايه قلت لكم هو شنو باثو؟ معناها ديزيز، معناها اسمه الثاني ديزيز ديس اوردر معناها organized، فشي مرتب نظام. disorder loss of this organization. وصحيح وياي على الخط طلاب؟ واضح كلامي بابا؟
واضح.
فإذا disease disorder معناها loss of either anatomical structure or physiological structure. قاعدة ذهبية خليها بكل حياتك الطبية. any disease there's either change in anatomy, physiology or both. simple. يعني انت سالتني عن المننجايتس، تيوبركلوس مننجايتس، اذا انت اكو ستراكشر عندك اللي هو برين والمننجز، وشنو عندك؟ هذا الستراكشر يؤدي لك الى فانكشن. طبعا اكو جنرال سيمبتومز اوف انفكشن، هذه معروفه واخذتوها في كل الانفكشنز، بالنمونيا، الكوليسيستايتس، الانفلونزا، هذه كلها احنا شايفين. اذا ما درستها فانت اكيد معرض الى انفكشن. ماكو واحد بينا ما صار عنده كومن كولد، مو صحيح؟ ماكو واحد ما صار عنده انفلونزا. هذه السيمبتومز الجنرال كونستيتيوشنال سيمبتومز اوف انفكشن انت ماخذها تعرفها ومعرض. اذا اكو لوكال افكت اوف انفكشن، هو مو بس الانفكشن طلاب. any disease any type of disease there is either change of in anatomy in the structure and the function of this structure. فاذا لا تدرخ any disease. هذه تساعدك في فهم الديزيزز، في التشخيص. any organ رأسا نتذكر شنو الفانكشن مالته. فمن سألت رأسا تخلي ببالك انه هذا الانفكشن التيوبركلوس مننجايتس الساين اند سيمبتوم تعتمد على السايت اوف infection and which function will be lost. شنو الفانكشن of the part of the brain which is involved by disorder, by necrosis, by infection, by tumor. زين. ومو بس ال CNS, any organ in the body which part is affected there is disturbance in the disorder. هو هذا تعريف الباثولوجي. disorder in the anatomy or physiology of particular organ. إن شاء الله هذه القاعدة الذهبية حاول تفكر بيها، وحاول كل ما تقرأ ديزيز حاول تطبق هذه القاعدة حتى لا تدرخ ويصير سهل عليك تجاوب. واضحة إن شاء الله طلاب؟
واضحة دكتور.
واضحة إن شاء الله؟ أوكي. إذن let us continue our lecture. We will talk about CNS trauma. طبعا الهيد انجري هي منين تجي CNS trauma in general. head injury. الهيد انجري طلاب نقسمها إلى penetrating and non-penetrating. penetrating معناها there is damage either to the skin with or without bone skull injury, or non-penetrating without loss of intactness of skin and bone. حتى لا ننساها خلينا نحفظها بهالطريقه. احنا شو نقول بالعاميه بالمثل الشعبي؟ لو طخ لو طلع مخه. سامعين هذا المثل؟ وياي طلاب؟ تسمعوني طلاب؟
نعم.
فلو نعم طلع مخ. It is either penetrating or non-penetrating. منين تجينا CNS infection الانجري؟ It is either by car accident, road traffic accident, blow ضربة يعني بوكسينج ذولا الملاكمين، أو ممكن يعني أي واحد يتكاون ممكن يتعرض there is hematoma يعني accumulation of blood. والcontusion تكون نوعين كوب and counter كوب. كوب and counter كوب. كوب are the site of injury, at the site of impact. يعني شخص مثلا ينضرب من الامام راسه. الكونتوجن اللي صارت بالانتيريور بارت اوف ذا برين هذه نسميها كوب. بالمقابل يعني البرين له حركه خفيفه داخل السكال، هذه الاكسلريشن ديسلريشن، يعني مثلا حادث سياره تسارع ثم بطء اكسلريشن ديسلريشن، فالضربه باتجاه الديفكت اللي يصير البروزز اللي صارت باتجاه الضربه في مكان الضربه نسميها كوب، وبالاتجاه المقابل لما البرين شويه يرجع للخلف ويضرب بالسكال نسميه كاونتر كوب. فالكوب at the same direction, same site of injury، والكاونتر كوب at diagonal reverse opposite site. واضح؟ إذا الكوب هو السايت اوف انجري، والاوبوزيت سايت نسميها كاونتر كوب. كونتوجن هي عباره عن سايت اوف كونتوجن يكون swollen edematous and with petechial هو يعني small injuries, small pinpoint like bleeding. petechial يعني pinpoint like نقطيه hemorrhage نقطي. There is swelling, edema, and petechial hemorrhage. Microscopically, there is edema, and extravasation of RBC اللي هو hemorrhage. إذن ما ننسى إنه concussion there is no gross, no pathological findings. بينما بالcontusion there is swelling, edema, and extravasation of RBC microscopically, which is manifested grossly as petechial pinpoint bleeding sites. Well, just to emphasize, there is coup or counter coup injury. Coup at the site of impact and counter coup at the opposite site of impact. Another type of or effect of CNS trauma is the intracranial hemorrhage. بالمناسبة intracranial hemorrhage أو CNS hemorrhage, it is of two types, either traumatic or non-traumatic. راح ناخذ في المحاضرات القادمة السيربروفاسكولار ديزيزز، الأمراض اللي تتعلق بالأوعية الدموية بالسنترال نيرفس سيستم، وهذه of two types, either traumatic or non-traumatic. يعني الشخص ممكن يرتفع الضغط عنده ويصير عنده rupture بالبلد vessels inside the brain leading to bleeding. This is intracranial hemorrhage without trauma. Type of traumatic intracranial hemorrhage involve extradural or epidural hematoma. Hematoma هي نفس الهيموريج نقصد بها accumulation of blood. The blood vessel usually severed or injured is the middle meningeal artery. Clinically, there is lucid interval followed by rapid increase in intracranial pressure and loss of consciousness. إذن there is injury to the. طبعا هنا طلاب بس أبدأ أنوه على فد مسألة بالتروماتيك intracranial hemorrhage. إذا كان الافكتد بلاد فيسل هو ارتري، تعرفون الارتري البلاد بريشر يكون هاي، لذلك accumulation of hematoma يكون rapid، لذلك symptom يصير rapid. يعني loss of consciousness و neurological deficit اللي يصير in case of arterial injury اسرع من البلد بريشر بالفين يكون لو، accumulation of hematoma يعني الهيماتوما تكبر بالارتيريال انجري اسرع مما تكبر فيما لو كان الانجري تو ذا فين. البليدنج بالفين عاده يكون اضعف مما هو بالارتري، لذلك السيمبتومز بالفينس الانجري تكون develop slowly. another type of bleeding هو السبديورال هيماتوما. إذا من نقول extradural أو epidural، epi معناها above. إذا الديورا هي الاكسترنال part of meninges. فالبليدنج وين صاير بين السكال وبين الديورا، السبديورال لا تحت الديورا. إذا epidural معناها فوق الديورا، والسبديورال below الديورا. الابيديورال قلنا arterial يعني middle meningeal artery affected، والسبديورال هيماتوما is a venous type of bleeding. لذلك هسه توني قلت أكدت venous bleeding develop slowly. وagain there is acute onset of increased intracranial pressure، واكو chronic presentation اللي هي loss of memory and confusion. طبعا نقطة مهمة هنا، يعني increased intracranial pressure، هل هذا مهم؟ طبعا مهم. ليش؟ لأنه increased intracranial pressure قلت لكم البرين lie inside a rigid space موجود داخل السكال ما تسمح لنا باكسبانشن الا في very limited. فمن يزيد البريشر نخاف من الهرنيشن. الفيتال سنترز اللي موجوده بالبرين ستيم من يصير هرنيشن patient will die. These vital centers such as respiratory and cardiovascular centers will be affected and death will occur. لذلك التيومر بالبرين والإديمة والهيموريج any space occupying lesion، يمر عليكم المصطلح space occupying lesion من اسمه any lesion whether tumor edema fluid cyst hemorrhage. هذه الليجنز space occupying يعني تاخذ مكان. مشكلتنا وين؟ مشكلتنا احنا ما عندنا مجال نتوسع، ماكو مجال للتوسع، السكال ريجيد. لذلك any lesion space occupying lesion will push the vital centers down. هذا الهرنيشن lead to death will affect the respiratory and cardiovascular vital centers. Let's come on then epidural and subdural hemorrhage. عندنا subarachnoid hemorrhage. طبعا subarachnoid hemorrhage قلت لكم هاي التايب اوف hemorrhage could be traumatic or non traumatic، رجاء لا تخلطون بيناتها. هسه احنا اليوم جاي نحكي فقط على التروماتيك، والمحاضرات القادمه راح تحكي على السيربروفاسكولار ديزيزز ومن عندها النون تروماتيك بليدنج. subarachnoid hemorrhage من اسمه hemorrhage into the subarachnoid space due to rupture of arteries. واجين كلها هذه راح تسوي لنا space occupying lesion، وبالنهايه increase intracranial pressure. وحسب السايز ممكن neurological deficit altered level of consciousness، ممكن اذا كان intracranial pressure rise substantially there will be affection to the vital centers and death. إذا أخذنا الإبيديورال subdural subarachnoid. Lastly we will talk about intracerebral hemorrhage into the brain substance due to rupture of small blood vessels and accumulation of blood in the cerebrum, in the brain substance. يعني مو خارج البرين وإنما داخل البرين. Again, there is increased intracranial pressure with focal deficits. This type of bleeding usually fatal. This type, طبعا هذه التروماتيك intracranial hemorrhage تحتاج تدخل جراحي سريع for evacuation. Otherwise, intracranial pressure will lead to death. تذكرون تحدثنا بالعملي على clinical condition called hydrocephalus. hydrocephalus. الترجمة الحرفية للهيدروسيفالس هي هيدرو معناها water وسيفالس معناها brain. فلذلك يترجموها بالعربي إلى استسقاء الرأس. وشفنا صور واضحة على الهيدروسيفالس. والهيدروسيفالس by definition there is increase in the volume of cerebrospinal fluid leading to dilatation or expansion of ventricles. When we see expansion, there is increase in the intracranial pressure. Then there is, by definition, hydrocephalus, there is increase in the volume of CSF with expansion or dilatation of the ventricles. من يصير dilatation شنو صار عندنا؟ space occupying lesion. وهذا space occupying lesion ايش راح يسوي؟ will lead to increased intracranial pressure. Why hydrocephalus happens? In the definition, cause and effect. There may be obstruction to the flow of CSF. طبعا بالعملي أنا تحدثت عن ال CSF circulation وشلون يتخلص الجسم من ال CSF. فإذا صار obstruction راح يصير accumulation of the CSF. ومن يتجمع ال CSF lead to dilatation of the ventricles. There may be impaired absorption of the CSF. يعني ماكو obstruction وإنما decrease in the absorption of CSF وهذا rare. There may be overproduction, increase in the production of the CSF by choroid plexus papilloma وهذا very rare. شلون ممكن نصنف what are the types of hydrocephalus? It is either non-communicating or communicating. By definition communicating hydrocephalus معناها اكو تواصل there is no obstruction, there is free circulation of the CSF. Okay. Communicating يعني متصل معناها there is free circulation of the CSF. طيب ليش يصير hydrocephalus إذا ماكو obstruction؟ there is decreased resorption of the CSF. ليش يصير decreased resorption؟ due to meningitis يعني هذا a complication of meningitis and fibrosis. وممكن يصير due to complication of hemorrhage وهذا الهemorrhage يصير ب organization and fibrosis. وهذا الفايبروسيس either اللي جاينا من اما sequelae of hemorrhage or sequelae of inflammation lead to decreased resorption of the CSF, accumulation of CSF, increased amount of CSF and dilatation of ventricles. Non-communicating hydrocephalus اسمه الثاني obstructive. من اسمه obstructive معناها due to obstruction of the CSF circulation عادة due to congenital anomaly or due to tumor. إذن tumor or congenital anomaly lead to obstruction to the circulation of the CSF and accumulation of CSF with dilatation of the ventricles. اكو certain type ممكن واحد يسأل يقول يعني ممكن الهيدروسيفالس يصير in elderly in adults؟ طبعا يصير in case of brain atrophy or cerebrovascular atrophy of the brain, reduction in the size of the brain and compensatory dilatation of ventricles. هذا النوع نسميه hydrocephalus ex vacuo. إذا بالامتحان إذا أسألك mention the types of hydrocephalus راح تقول لي communicating, non-communicating or obstructive hydrocephalus and hydrocephalus ex vacuo. والcause of either of which communicating usually due to scarring and fibrosis after meningitis or hemorrhage. There may be obstructive hydrocephalus due to either congenital anomaly or tumor. والhydrocephalus ex vacuo due to brain atrophy following degenerating diseases such as Alzheimer's disease or due to cerebrovascular disease such as stroke. وبالعملي شفنا صور واضحه للإفكت اوف hydrocephalus بالانفانت بالchildren before closure of bones of the skull. There will be deformity and expansion of the enlargement of the skull وincreased intracranial pressure. وقلنا الإفكت of increased intracranial pressure. There may be also focal neurological deficit due to damage of certain sides of the brain by increased pressure. اكتملت محاضرتنا لهذا اليوم. Just to flashback, احنا تحدثنا عن developmental or congenital anomalies اللي هي neural tube defect وعددناها into anencephaly, encephalocele or spina bifida وذكرنا types of spina bifida. وتحدثنا عن CNS infection المننجايتس والانسفلايتس والبرين ابسس. وتحدثنا عن CNS injury وقلنا ممكن يصير laceration، ممكن يصير concussion، contusion والسب arachnoid subdural or epidural hemorrhage traumatic hemorrhage. وتحدثنا عن hydrocephalus وعرفناها انه هي increased amount of CSF with expansion of the ventricles وقسمناها الى communicating, non-communicating and hydrocephalus ex vacuo. عندنا الفيديو كليبس نحاول نشوفها مع بعض.
With meningitis,
طلاب الكل شايفين الفيديو؟
First, the meninges, which are 3 protective membranes that cover the brain and spinal cord. And with meningitis, meninge refers to the meninges, which are 3 protective membranes that cover the brain and spinal cord. And itis refers to inflammation. So meningitis is an inflammation of the meninges. More specifically, it refers to inflammation of the 2 inner layers, which are called the leptomeninges. The outer layer of the meninges is the dura mater. The middle layer is the arachnoid mater, and the inner layer is the pia mater. These last 2, the arachnoid and pia maters, are the leptomeninges. Between the leptomeninges, there's the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them for impact and bathing them in nutrients. In 1 microliter or cubic millimeter, there are normally just a few white blood cells, up to 5. If we look at a bigger sample, like say a deciliter, then around 70% of those will be lymphocytes, 30% will be monocytes, and just a few will be polymorphonuclear cells, or PMNs, like neutrophils. That same volume will have some proteins in it as well, about 15 to 50 milligrams, as well as some glucose, about 45 to 100 milligrams, which is close to 2/3 of the glucose we'd find in the same volume of blood. The cerebrospinal fluid is held under just a little bit of pressure, below 200 millimeters of water, which is just under 15 millimeters of mercury, which is less than 1/5 of the mean arterial pressure. Now, at any given time, there's about 150 milliliters of cerebrospinal fluid in the body, and this is constantly replenished, with around 500 milliliters of new cerebrospinal fluid produced every day, and the excess, or 500 minus 150, or 350, is absorbed into the blood. But for any nutrients to enter or leave the cerebrospinal fluid, and the brain itself for that matter, they have to go through the tightly regulated blood-brain barrier. The blood-brain barrier is a special name given to the blood vessels in the brain. That's because the endothelial cells in the blood vessels are so tightly bound to one another that they prevent leakage and only allow certain molecules to slip through them. Meningitis is the inflammation of the leptomeninges, which remember are the inner 2 membranes around the brain and spinal cord. It is not the inflammation of the brain itself. That's encephalitis. But sometimes they can happen together, and when that happens, it's called meningoencephalitis. So meningitis needs some kind of trigger for the inflammation. And this could be an autoimmune disease where the body attacks itself, like lupus, or the body having an adverse reaction to some medication, which can happen with intrathecal therapy, when medication is injected directly into the cerebrospinal fluid. But by far, infection is the most common trigger for meningitis across all age groups, like with the Neisseria meningitidis bacteria or herpes simplex virus. Now, there are 2 routes that an infection can take to reach the cerebrospinal fluid and leptomeninges. The first way is direct spread, which is when a pathogen gets inside the skull or spinal column and then penetrates the meninges, eventually ending up in the cerebrospinal fluid. Sometimes the pathogen will have come through the overlying skin or up through the nose, but it's more likely that there's an anatomical defect to blame. For example, it could be a congenital defect, like spina bifida, or an acquired one like a skull fracture, where there might be cerebrospinal fluid leaking through the sinuses. The second way is hematogenous spread, which is when a pathogen enters the bloodstream and moves through the endothelial cells in the blood vessels that make up the blood-brain barrier and get into the cerebrospinal fluid. To do this, the pathogens typically have to bind to surface receptors on the endothelial cells in order to get across. Otherwise, they have to find areas of damage or more vulnerable spots like the choroid plexus. Once the pathogen finds a way into the cerebrospinal fluid, it can start multiplying. Soon enough, the handful of white blood cells surveilling the cerebrospinal fluid identify the pathogen and release cytokines to recruit additional immune cells. Over time, a microliter of cerebrospinal fluid might go on to contain thousands of white blood cells, but any more than 5 usually defines meningitis. In most bacterial cases, there'll be above 100 white blood cells per microliter, and more than 90% polymorphonuclear cells. In most viral cases, there'll be 10 to 1,000 white blood cells, and over 50% lymphocytes and under 20% PMNs. In most fungal cases, there'll be 10 to 500 white blood cells, with over 50% being lymphocytes. In most cases of tuberculosis meningitis, there'll be 50 to 500 white blood cells, with over 80% being lymphocytes. The additional immune cells attract more fluid to the area and start causing local destruction as they try to control the infection. As a result, the cerebrospinal fluid pressure typically rises above 200 millimeters of water. The immune reaction also causes the glucose concentration in the cerebrospinal fluid to fall to below 2/3 of the concentration in the blood. It also makes the protein levels increase to over 50 milligrams per deciliter. When When it comes to the causes of meningitis, viruses and bacteria usually cause acute meningitis, whereas fungi usually causes chronic meningitis. Now, for bacteria, there are a lot of possibilities. In newborns, the most common causes are group B streptococci, E. coli, and Listeria monocytogenes. In children and teens, the most common causes are Neisseria meningitidis and Streptococcus pneumoniae. In adults and the elderly, the most common causes are Streptococcus pneumoniae and Listeria monocytogenes. There are also tick-borne causes of meningitis, like Borrelia burgdorferi bacteria, which is the cause of Lyme disease. As for viruses, the main culprits are enteroviruses, especially Coxsackie virus, as well as herpes simplex virus. HIV is usually contracted through body fluids and can also cause viral meningitis. Less common causes include the mumps virus, varicella zoster virus, and lymphocytic choriomeningitis virus. There's also the fungi, like those from the Cryptococcus and Coccidioides genuses, which mainly affect immunocompromised individuals. And then, of course, there's tubercular meningitis, which is caused by the Mycobacterium tuberculosis bacteria. And finally, parasitic causes of meningitis, like P. falciparum, which is the main cause of malaria. Now, the classic triad of meningitis symptoms are headaches, fevers, and nuchal rigidity, or neck stiffness. It can also cause photophobia, which is discomfort with bright lights, or phonophobia, which is discomfort with loud noises. Meningoencephalitis can cause an altered mental state or seizures. The diagnosis of meningitis starts with a physical exam. One maneuver is when a person lies flat on their back facing upwards, and one of their legs is raised with the knee flexed to a 90-degree angle. Then the leg is supported and slowly straightened at the knee. If this causes back pain, then it's called Koenig's sign. Another maneuver is when a person again lies flat on their back facing upwards, and then has their neck supported and flexed. If this causes them to automatically flex their knees or hips, then it's called the Brzezinski's sign. If meningitis is suspected, a lumbar puncture can be done. This is when a needle goes through the lower lumbar vertebral levels of the spinal cord, between L3 and L4, for example. The needle penetrates into the subarachnoid space and a few milliliters of cerebrospinal fluid is taken. The opening pressure can be measured, and the cerebrospinal fluid can be analyzed for white blood cells, protein, and glucose. Polymerase chain reaction, or PCR, might also be used to find specific causes, like HIV, enteroviruses, HSV, or tuberculosis. If a particular infection seems like an obvious cause, then a test for that might be used, like the Western blot for Borrelia burgdorferi bacteria, or a thin blood smear for malaria. The treatment of meningitis depends on...
طلاب نشوف مقطع آخر.
The terms...
طلاب الكل شايفين الفيديو؟ طلاب الكل ظاهر؟ نعم، اوكي.
The term spina bifida comes from the Latin split spine, which is actually a pretty good description because spina bifida is a birth defect where the tissue on the left and the right side of the back that normally come over the spinal cord to protect it don't completely meet up to form a nice seal, leaving behind various degrees of an opening right down the middle of the lower back. Very early on in fetal development, the ectoderm, which is the outer layer of the fertilized egg, starts to develop a bit of a ridge that eventually becomes the neural tube. This neural tube goes on to become the spinal cord, the brain, as well as tissues that enclose and protect them, called the meninges. And spina bifida occurs when a portion of this neural tube fails to close properly, typically in the lower back. This constitutes a defect or absence of the vertebral arches due to a failure of mesoderm to organize over the region of the defect, and it may or may not involve the underlying meninges in neural tissue. Alright, so there are three main types of spina bifida, and the first is myelomeningocele, also called meningomyelocele. And this is the most severe of the three and happens when the spinal cord and the surrounding meninges protrude out of an opening in the bony vertebrae and are held together by a sac of skin that pouches out from the back. In really severe cases, there's no skin at all, and the nerves of the spinal cord are therefore exposed, a condition called open spina bifida. And this can cause serious damage to the exposed nerves, as well as risk an infection, resulting in symptoms like loss of sensation or paralysis in the areas of the body below the damaged site, bladder or bowel movement problems, seizures, as well as leg and foot deformities. Now, a myelomeningocele is typically associated with a condition called an Arnold-Chiari 2 malformation, which is where cerebellar and brainstem tissues slip down into the foramen magnum, the opening at the base of the skull. This Arnold-Chiari 2 malformation results in a variety of symptoms related to the cerebellum, and often results in hydrocephalus, an abnormal accumulation of cerebrospinal fluid in the brain. Alright, the second type of spina bifida is meningocele, sometimes called a meningeal cyst. In this condition, the prenatal spinal deformities result only in the meninges and not the spinal nerves, slipping into the gaps between the deformed vertebrae. This one's the least common form of spina bifida, and because the spinal cord itself isn't damaged, these individuals often don't experience the severe symptoms that are seen in myelomeningocele. Alright, the third and final type is spina bifida occulta, and this is the most common and most mild form of spina bifida. In fact, occulta is Latin for hidden, which is appropriate since many of the normal prenatal tests used to diagnose spina bifida don't catch the disorder because the deformities in the tissues of the lower back are tiny. In spina bifida occulta, the spinal cord and surrounding tissue don't protrude, nor is any of the tissue forced into spaces between the vertebrae. Since the spinal nerves are undamaged, people with this form of the disorder are often asymptomatic, and the condition is usually only found accidentally later in life. At most, people might have hair, a dimple, or a birthmark on their back above the site of the lesion. Now, the exact cause of all three types of spina bifida isn't known, but there are known risk factors, like folate or vitamin B9 deficiency during fetal development. And therefore, prenatal vitamins include folic acid, which is the manufactured form of folate. The developmental deformities, though, that cause spina bifida often take place in the 4th week of pregnancy, which is 21 to 28 days. And this could be before a woman might know that she's even pregnant, and therefore she's not taking the prenatal vitamins yet. To help combat this, enriched grain products like breakfast cereals made with whole grains have folic acid added to the flour as a general preventative measure. Other risk factors for having a child with spina bifida include obesity, poorly controlled diabetes, and taking medications that interfere with folate metabolism, like certain anti-seizure medications. Diagnosis for the most severe form of spina bifida, myelomeningocele, is often done prenatally by looking for an increased level of alpha-fetoprotein, or AFP, in the mother's serum, which can happen when the skin surrounding the fetus's spine is missing and AFP leaks into the amniotic fluid and into the mother's bloodstream. AFP, though, can be elevated in other conditions as well. So in order to get a more exact diagnosis, additional blood tests for human chorionic gonadotropin, or HCG, inhibin A, and estriol, as well as an ultrasound, are usually done. In more serious cases, amniocentesis, where a sample is taken directly from the amniotic sac surrounding the fetus, can be performed. For treatment, prenatal surgery is done to close a myelomeningocele, but this surgery can be dangerous to the developing fetus as well as the mother. It can be repaired. Alright, not very severe. And myelomeningocele, which is or spina bifida occulta, which is the most common and least severe. Meningocele, which is the least common and also typically not very severe. And myelomeningocele, which is the most severe form of spina bifida. Thanks for watching. You can help
Thank you very much. بس نشوف هذا الفيديو القصير وثم ننهي السيشن.
Welcome to 2-Minute Neuroscience, where I explain neuro.
طلاب الكل شايفين هذا الفيديو واضح بالنسبة لكم طلاب؟
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss hydrocephalus. Hydrocephalus is a condition that involves the buildup of cerebrospinal fluid, or CSF, a fluid that is produced in the cavities of the brain known as the ventricles. CSF flows through and around the brain and spinal cord and is eventually absorbed into the bloodstream. It serves a number of functions, including acting as a cushion, delivering nutrients, and removing harmful substances. Hydrocephalus can occur due to excess production of CSF, impaired reabsorption of CSF into the bloodstream, or a blockage in the ventricular system that causes CSF to accumulate. Hydrocephalus is mainly classified as either communicating or non-communicating. Communicating hydrocephalus does not involve a blockage in the ventricular system. Non-communicating hydrocephalus involves a blockage and is the most common cause of hydrocephalus. Hydrocephalus can be present at birth or it can be acquired later in life. When CSF accumulates in the ventricles, this causes the brain to become enlarged. The increased brain size can lead to increased pressure in the skull, which can lead to the compression of the brain and a variety of symptoms, some of which may be life-threatening. When hydrocephalus occurs in infants, their skull is more capable of expanding, so their heads often become enlarged, but there may be more time before the onset of other symptoms. In adults, however, the skull does not generally expand, and symptoms may appear more quickly. Treatment for hydrocephalus involves an attempt to drain the excess CSF, and often this involves using a cerebral shunt. A cerebral shunt is a plastic tube connected to a catheter. One end of the catheter is placed at the site of increased pressure in the ventricles, and the other is often placed in the lining of the abdominal cavity. CSF is diverted to the abdominal cavity, where it can safely drain.
Thank you very much, students. ننهي السيشن